morning, everyone. I'm Sharon Trivett of the Department for Public Health. I want to welcome you to today's training. We're going to be going over some Medicare updates and the preventive services updates from CGS. We have Melissa Kress with us. She's a senior provider representative with CGS, and she's been gracious enough to come to Frankfurt and put this on for us. You all should have the PowerPoints to follow along with. We sent those out last week. If you don't have them, you can email the help desk or just follow along, and we can send them out to you afterward. And as long as we don't have any other issues, connection issues or anything, we're going to go ahead and get started. Melissa Kress.
Good morning, everybody. My name is Melissa Kress, and I'm with CGS Administrators for your Part A BMAC. A little bit about me. I've been doing work for CGS for about 9 years. I've worked in about 5 different departments, so I have a little bit of everything knowledge coming into this. I've been with Provider Outreach and Education for about a year. What we're going to do today is we're going to do the Medicare Updates Workshop. It is the spring workshop for 2013 that'll have your most basic Medicare updates. A little later, we'll be doing the Preventative Services webinar. I'm usually the webinar girl, so if you have ever called into a webinar, you may have heard my voice. So let's hope we have a really great presentation today, and we'll go ahead and get started. Okay, on slide 2, we're just talking about the general disclaimer that CGS makes. Basically what we're doing is we're indicating that Medicare policy is changing frequently. I'm sure you all know that. So anything that we have put into this presentation has source documents that will give the information for the references. It's a general summary, and the official Medicare program provisions are contained in the relevant laws, regulations, and rulings. Okay, we have 3 very simple objectives for this training today. We want to discuss new and updated Medicare initiatives. These are all the initiatives that are currently going on in our world that may be affecting you directly. We are providing the CGS operational reminders, which is the different departments within CGS and things that are going on with them that may have an effect on you. And we're also going to introduce some resources and some new self-service technology options. We do have the MyCGS interactive web portal. Those kinds of self-service can always help your offices in finding your information. Okay, we're going to start with Medicare Initiatives. We're going to go over sequestration, place of service updates, ordering and referring physicians, claims-based data collection for outpatient therapy services, ESMD, provider enrollment revalidation, ICD-10 implementation, and CMS's training for medical identity theft. Okay. And I know this is kind of relevant information that you've been hearing about previously, and that's sequestration. Basically what the Budget Control Act of 2011 required was mandatory across-the-board federal spending cuts. And that's for a lot of different offices. The American Taxpayer Relief Act of 2012 delayed that sequestration for Medicare for about 2 months. All your dates of service after April 1st, 2013 had claims incurring a 2% reduction in Medicare payment. Now, what's happened with that is that you've been seeing that information on your previous screens, is that you've been seeing that on your remits for that 2%. Basically, any update from that is going to require congressional action to avert that payment reduction for that to be taken off the board. They're looking at rethinking that at the end of 2013 when they make the fee schedule adjustment changes. When the final rule comes out, that fee schedule will always change. Now, as for that fee schedule information, we always have a reduction put in place. They always, as part of the final rule, say we're going to reduce Medicare payments by usually a very large percentage, somewhere in the 20 to 27% range. And usually at the last minute, Congress overrides that rule, and then we go ahead and make that change and have it be updated. We are not sure how that's going to go in the final rule this year. We're never quite sure. So what we want to make sure you do is just be prepared, have your final rule information ready. They will have a comment period probably starting in September or October. That's an opportunity for you to give feedback on that final rule. So just be watching that information. We'll have that on our listserv, and you can go ahead and get that started. Okay, some questions and answers that maybe you need to review is that 2% payment reduction applies to the Medicare fee-for-service schedules. And no, it doesn't. It only applies to the final payment of the claim. Basically, what we're going to do is just take 2% off the top. You'll be getting CART code 223, which you've probably seen, for the adjustment code for mandated federal, state, or local law regulation that is not already covered by another code. At the bottom of the slide, you can see that payment calculation information, which will show you exactly how claims process. If you need more information, that's a really great reference for you. Okay, the ordering referring provider edits. This is one of the slides that we reference in the disclaimer because this information obviously has changed. We have been looking at ordering referring provider edits literally since 2009. What happened with the 2009 dates of PECOS, we've been looking for PECOS for ordering referring provider information. Now, we've been telling you all this time, if something is not on the referring or ordering provider list, you'll get a remark code of N265, and it will say, referring or ordering provider is not eligible to bill services. We go ahead, we process the services, and we pay the services. However, originally on May 1st, 2013, they were going to stop paying those services. If the ordering or referring provider wasn't listed in PECOS and they didn't have their MPI information in the PECOS, we weren't going to pay the claims. However, that's been delayed through CMS. However, it is coming. So what you want to make sure is to figure out your ordering and referring providers and make sure that they're listed in PECOS. Because obviously you don't want your claims denied for those services for those ordering and referring. Now, there are a list of specialties that are allowed to order and refer services. You have your doctor of medicine, your doctor of osteopathy, your doctor of podiatric medicine, your doctor of optometry, your doctor of oral surgery, your doctor of dental medicine, your physician assistants, your nurse practitioners, your clinical nurse specialists, your certified nurse midwives, your clinical social worker, and your clinical psychologist. Okay. Again, we talked about phase 1, and phase 1 is still in play until they update to phase 2. Now, basically, what you're getting the information that the ordering referring provider is required for that billed service. If the ordering referring provider information is not on the claim at all, the claim will reject. If the ordering referring provider is on the claim, Medicare will verify that information in PECOS. And if the information is not in PECOS, or is in PECOS but not of the type or specialty allowed to order and refer, the claim will continue to process. Okay. And then, of course, phase 2, which is coming in shortly, is your ordering referring provider is required for the billed services. If that ordering referring provider, again, is not on the claim at all, the claim will be rejected. If the ordering referring provider is on the claim, Medicare will verify that the ordering referring provider is in PECOS and eligible. If the ordering or referring is not in PECOS or is in PECOS but not of the specialty allowed to order or refer, the claim will be rejected. Okay. The important thing to know is that if you submit services based on orders or referrals from other providers, you're going to watch for the N264 and the N265 codes. If you are seeing a lot of these codes on your services, that's indicating that the doctor that you're using to refer or order services is not in the PECOS system. Now, if you realize your doctor is not in PACOS, you may want to start indicating to your doctors that they need to enroll in PACOS in order for you to take those services. This is really important for labs and radiology services, because if you're referring those services, oh, I'm so sorry. I apologize. We were having microphone problems. But if you're still getting those reason codes, you probably want to check with your doctor's information and make sure that they are in PACOS and listed appropriately. You will see N264 and N265 both on the services you're receiving now, and then once phase 2 comes out, those will be on your denied services. But you want to make sure you're getting paid, so go ahead and take care of that now. Okay, so how do you verify that information? You can go out to the Ordering Referring Providers Enrollment in PACOS. And what you can do is use that internet-based PACOS system to look and make sure the doctor has a PACOS record. They have an Ordering Referring report. And what you can do is go out there, and it has a very large list of providers listed by first and last name, where you can actually check that Ordering and Referring report to get that information. Now, if you are an office that orders and refers services a lot, you can provide your individual MPI for your referrals. Yes, it's the individual MPI that will be used to order and refer services. You don't want to use your group information. There's more information on the CMS LMN Matters article, and that's Special Edition SE 1305. Another hot topic that we've been talking about a lot recently is provider enrollment revalidation. This is a requirement established by the Affordable Care Act. What's going on is all providers that were enrolled prior to March 25th, 2011 is going to be subject to revalidation. Now, everyone's going to be revalidated before March 23rd, 2015. So if you were enrolled before March 25th, 2011, you're going to receive a revalidation letter. Basically, that revalidation request will be mailed in the yellow CGS envelope. You can see it at the bottom right-hand corner of your presentation. It will be sent to the correspondence, special payments, or practice address. So you want to make sure that if that yellow envelope comes in, that it gets to the appropriate party. Now, if you're not sure you've been sent a notice, if you just want to make sure that you've gotten your information correctly, there is a list of providers that have been sent notices to revalidate. They are on the CMS website. You can click on the link in the presentation to go directly out there. The other hot topic that we kind of have going on right now is ICD-10-CM. Now, the ICD-10 implementation date is October 1st, 2014. Now, that's a year away, and a lot of providers are saying, hey, I'm not going to worry about that yet. You need to worry about it. What's going on is that once that ICD-10 implementation date comes in, if you are still billing ICD-9, if you are not ready, you will not be getting paid. Now, basically, what's going on with the LCDs, we have a couple of timeline dates for you. The first one is current and any new LCDs are being translated from ICD-9 to ICD-10 and will be completed it's supposed to be completed by June 2013. They are still working on some of the ICDs, the ICD-10s for those LCDs, but they will be updated shortly. Now, the LCDs will be loaded into the database beginning in October 2013. There's testing of new edits for the ICD-10, and that'll be an ongoing process through March 13th through 2013 through September 2014. So we're already testing edits to make sure that things are working correctly. Now, all LCDs will be available on the CMS website with the ICD-10 translation by April 1st, 2014. That way you'll have plenty of time to get prepared, look over our local coverage determinations, and make sure that you're going to be billing the correct thing for your services. As NCDs are completed, or your national coverage determination, those will be updated and published on the CMS website, as well as the CGS website when they're completed. Those NCDs are being translated. Those national coverage determinations are processed by CMS, so they're doing those as they go along. What you want to do is make sure that your offices are keeping up to date on ICD-10. You're going to visit the CMS ICD-10 website for the latest news and resources. For practical transition tips, you want to make sure to read your recent ICD-10 email update messages, and you want to access the ICD-10 continuing medical education modules developed by CMS in partnership with Medscape. They have a lot of great education modules that will walk you through the LCD update process, including helpful tips such as getting in touch with your vendors, making sure that they're up for that transition too. Okay. The final thing in this particular section is the CMS Medical Identity Theft web-based training. There is a web training called Safeguarding Your Medical Identity course, and it's going to help you recognize the risk of medical identity theft and the resources available to protect your medical identity. That's available through the CMS Medicare Learning Network. There are CEU credits available for this course. Something else I always like to point out when we talk about CMS training, they also have a Medicare training series. And basically what it is it's a series of 18 different classes. And if you complete all 18 classes, you do get a certificate in Medicare billing. So that's something to think about if you're wanting to kind of have something else to add onto your resume or to look at. They do have that information out there. So definitely go out and check out the Medicare Learning Network. Okay, we're going to talk a little bit about Medicare Incentives. I know some of the deadlines have come and passed, but we're going to go ahead and go over them anyway. We're going to talk about PQRS, the Electronic Prescribing, or ERX, the Physician Compare website, and electronic health records. Okay. For PQRS, or the Physician Quality Reporting System, basically what this is a reporting program that's going to use a combination of incentive payments and payment adjustments to promote reporting of quality information by eligible professionals. It's going to provide an incentive payment to practices with eligible professionals who satisfactorily report data on quality measures for covered physician fee schedule services. And it's going to be for Part B fee-for-service beneficiaries, and that does include railroad retirement and Medicare secondary payer. PQRS, again, is mandated by the federal government, and there's no sign-up or registration required to participate. Okay, so PQRS eligible professionals. The physicians list includes Doctor of Medicine, Doctor of Osteopathy, Doctor of Podiatric Medicine, Doctor of Optometry, Doctor of Dental Surgery, Doctor of Dental Medicine, Doctor of Chiropractic, Physician Assistants, Nurse Practitioners, Clinical Nurse Specialists, CRNAs, Certified Nurse Midwives, Clinical Social Worker, Clinical Psychologist, Registered Dietitian, Nutrition Professional, and Audiologist, and also Physical, Occupational, and Speech-Language Pathologist. Okay, we have a couple of really great guides for you. The first one is your PQRS Implementation Guide for 2013. It does walk you through the sample measures and correct coding, as well as claim submission examples. So it will give you the information that you need to bill for PQRS. It'll give you the information on how to participate. That's for eligible professionals that are required that we just went over. Your reporting options and periods, your measure codes and measure groups, satisfactorily reporting scenarios. Now this is available in the download section of the CMS PQRS webpage. So you can go out there, get your implementation guide, take a look to try to incorporate. Okay. Now we're going to talk a little bit about value-based modifiers, which is kind of related to PQRS, because PQRS is going to be the basis for the building blocks for value-based modifiers. What they're going to be doing is providing comparative performance information to physicians, What they're trying to do is improve the quality and efficiency of medical care by moving physician reimbursement, rewarding value rather than volume. And this is going to apply for fee-for-service Medicare only. And what it's going to do is provide meaningful and actionable information to physicians that will help improve the care they deliver. What they're looking for is that the patients are getting services that are valuable to them rather than volume. A provider, for example, a provider who is treating 4 patients an hour as opposed to 6 patients, but giving better value-based services, may get paid better through this physician reimbursement value-based modifier system. This is upcoming. They haven't gotten all the details worked out on it, but it's coming. So that we're looking for that in the future. Okay, now we're going to talk a little bit about e-prescribing. Electronic prescribing is an incentive program for those who transmit prescriptions electronically. There's a reduced chance of medication dispensing errors due to ineligible handwriting. It also creates fewer contacts between the physician and the pharmacy. They can go ahead and get that information into them quickly. The method to check for more affordable drugs and those that may be contraindicated. It does make it easier to look for the generics of services. This is mandated by the federal government, and again, there is no sign-up or registration required to participate. Again, the ERX eligible professionals looks exactly like the ones for PQRS because they are exactly the same. Okay, we have the reporting limitations. Now, there's obviously incentives for eligible professionals who are authorized under their respective state laws to prescribe medication electronically. Ohio State Board of Pharmacy and the Kentucky Board of Pharmacy has both that information. For example, in North Carolina, I can speak that they will not send any sort of narcotics electronically. I don't know how your state sits on that, but there's probably similar laws. So you just want to make sure that you have the basis for that. They have to use a qualified electronic prescription system. There's a list of that electronic prescription system on the CMS website. And at least 10% of the medical professionals' Part B covered services must be made up of the codes that appear in the denominator of the electronic prescription measure. Okay, we're going to go into that 2013 reporting, and you want to report the ERX measure for at least 25 events. Your numerator is going to be HCPCS code G8553, and that's going to be for at least one prescription created during the encounter was generated and transmitted electronically using a qualified ERX system. You can send one or more for one encounter, and they're all going to be under that one code. So you have to have 25 different patient events in order to bill the G8553 for reporting purposes. Now, if you look at a list of those CPT codes listed below for your denominator criteria, if you're looking at those codes and you say, you know, my office isn't billing 10% of those, that's going to be your measure to know that you qualify for ERX. If you're billing these codes, you do need to be billing ERX. Okay, we're going to start talking about the incentive and payment adjustments. Obviously, there was a 5% incentive if you were qualified for electronic payments for electronic prescribing. There will be a 1.5% payment reduction for eligible professionals who were unsuccessful reporters in year 2011, failed to submit 10 ERX codes by June 30th, 2012, or did not request and receive a hardship exemption. And there's a 2% payment reduction for the year of 2014. Now, incentives and payment adjustments. Basically, how to avoid the 2% reduction for 2014. If you reported correctly in 2012, you avoided the adjustment. Now, any eligible provider not enrolled in MPPES as one of the applicable specialties by June 30th, 2013. So if you're not one of the applicable specialties, obviously you can't be charged a 2% reduction. your eligible professional does not have at least 100 cases or less than 10% containing an encounter code in the denominator by January 1st through June 30th, 2013. So if we go back and we look at these denominator codes, if you've billed less than 100 or 10% of your codes are not those, if you don't have more than 10% during your encounters, you're automatically avoiding that 2% payment reduction. If you reported the G code 10 times between January 1st and June 30th, 2013, or you request a hardship exemption. Now, you can do that two ways. You could submit the hardship exemption HCPCS G codes or making the request through the Physician Quality Reporting Communication Support page. However, that had to be completed by June 30th, 2013 in order to request that hardship exemption. If you have requested a hardship exemption and you have not heard back, you can contact QualityNet, which is your next slide, for any PQRS or electronic prescribing assistance as beginning participation, accessing your feedback reports, any explanation of feedback reports. They are also the ones who process the hardship exemption, so you can contact them about those. Their number is 866-288-8912. They are available 7 a.m. to 7 p.m. Central Time, Monday through Friday. You may get better results emailing them directly. There's an email address at the bottom of the page. On slide 28, we're going to talk about the Physician Compare program. Basically, this is a healthcare professional directory on Medicare.gov. Medicare.gov is your beneficiary page. They're the ones who go out there. The beneficiaries go out there and can look at Physician Compare to compare physicians in their local area. What we're wanting to do is help consumers make any informed choices about health care that they receive. They can search for physicians and practitioners by name, address, phone number, specialties, clinical training, and genders. It will tell them if there's languages spoken other than English, what affiliations with hospitals they have, whether they're accepting new Medicare patients, if they accept the Medicare approved amount, billing no more than the Medicare deductible and coinsurance, basically if they're Medicare participating providers. And it also gives them information about participation in PQRS or electronic prescribing. Okay. Now we're going to start talking about EHR for your electronic health record information. This is Health Information Technology for the Economic and Clinical Health Act. It's part of the American Recovery and Reinvestment Act of 2009. The law provides opportunities to improve health care through health information technology. It also promotes electronic health records through incentive programs for meaningful use of certified electronic health records technology. There's a timeline fact sheet on the Health Information Technology website. It provides key milestone dates for the EHR program, as well as resources to help providers address each milestone. Okay. The requirements for EHR is being, again, eligible professional, which is your doctor of medicine or osteopathy, doctor of dental surgery or dental medicine, doctor of podiatric medicine, doctor of optometry, and chiropractors. EPs must register, have an active NPES account, an NPI number, use certified EHR technology, and be enrolled in PACOS to qualify for the EHR incentive. Okay. Again, we're talking about a chart with your calendar year information. Again, it is not too late to get in to try to get some of these incentives. Obviously, you know, if you started this year, you could get a total of $39,000 in order to get some incentive for that. We go ahead and encourage that early registration. If you don't have the system in place, you can ensure that you're enrolled to get those incentives early. You know, if you're thinking, if your doctors or our office is thinking about getting in, they can go ahead and register. Now, if you're an eligible professional, you can participate in Medicare or Medicaid, and you can switch one once during 2012 and 2014. So if you register with Medicare and you think you could get paid better with Medicaid, you can switch to that in 2014. Okay, now we're going to go into the CGS operational updates. This is going to be your departmental tips and updates that's going to make your lives easier. And you're going to learn a little bit about our departments and kind of how we work. Okay, so we're starting with our claims department, and we're talking about paper MSP claims. We have a lot of offices that are still submitting paper claims in Kentucky, so you want to make sure that if you're filing paper claims that you're submitting the complete primary explanation of benefits on that CMS 1500 claim form. Now, what does that complete EOB consist of? You want to make sure that it's on the letterhead for the name of the insurer. You want to make sure that's clean and concise. You want to have that your claim information matches what you're sending in. So you want to make sure your dates of service, all your claim information, all your payment information is there. You want to make sure that the claim adjustment reason code is on that claim. They have the same sorts of codes that we have on our remittance. We do need those. And we also need a copy of the glossary and the CARC explanation. I know those are usually at the end of your remittance. We do need a copy of that in order to complete your request. Okay, more claims information. We're going to talk a little bit about the correct coding initiative. Now, basically what CCI does is they identify pairs of services that normally would not be billed by the same physician for the same patient on the same day. Now, you can go out to the website, which is on the CMS website, and compare and contrast different CPT numbers. Now, when you go out there, if there's a CC code pair and it has a 0 indicator, that means it can't be reimbursed separately. And that's even if you add the modifier or even if you submit that in for an appeal, those are not going to be payable. Now, if the indicator indicates a 1, that means the services may be submitted with a modifier if the documentation in the medical record is supportive. Now, there's 3 different modifiers. There's modifier 25 for evaluation and management services. There's modifier 59 for procedures and diagnostic radiology services. And there's modifier 91 for lab services. Now, you want to make sure that your documentation supports the distinct and separate nature of the 2 services. If those services are audited and they do not show distinct and separate, that money will be taken back. Okay, now we're going to start going into overpayment requests. Those overpayment requests and demand letters, when you get those, are going to be sent in light blue envelopes. The requests for the repayment of Medicare funds are time sensitive, and we hope that the change in envelope color will help you quickly identify these requests. What we're hoping is that when you get that blue envelope that you'll treat it timely. After 30 days, if we haven't heard back from you, we're going to send another letter out. After 45 days, we are going to take the money back with additional interest. You want to make sure that your staff, practice, or place of business watches for those light blue envelopes so you can take the appropriate action quickly. I know a lot of practices have their own financial department, and those financial departments can get that information quickly if handled correctly. Okay. Another option, though, if you are getting overpayment requests, is to use immediate offsets. Now, when Medicare initiates an overpayment request, you can request that that overpayment be immediately offset. Now, for additional information from CMS about immediate offsets, you can go to Medlar Matters article MM7688. Now, what this can be done is to use for a one-time offset or to authorize offset of all future overpayments. And that's the form on the CGS website. It's also pulled up here. Now, what that means for one-time offset or future offsets, let's say your patient, Joe Smith, comes in and you provide services and you bill something in error for Joe Smith. And you say, you know what, I want to go ahead and have that immediate offset. So You can send that letter in and say, Joe Smith, we billed for a colonoscopy, but he never received it. So what they'll do is they'll send you out a letter saying, hey, Joe Smith, we're taking the money back on Joe Smith. You'll see it on your next remit notice. Now, to authorize offset of all future overpayments, what will happen is if Medicare has an offset, they'll go ahead and take the money back. They'll still send you a notice. It'll still be on the remittance, but you'll get that immediately, as opposed to having to wait the 30 days or take a chance on having interest applied. Some provider offices prefer that to go ahead and be able to track those overpayments. But that's completely up to you. The form will do either. Okay. Now we're going to go into our medical review department. And we're talking about diagnosis coding. Now, we're always reminding providers that you want to submit those diagnosis codes to the highest level of specificity. So ICD-9 codes obviously have 3, 4, or 5 digits. You want to make sure that you're coding to the most specific level in your current CPT book. Now, there's a lot of questions about rule-out diagnosis. So when you're ruling out a diagnosis, you're going to code based on the test results. So in your situation, if your physician confirms a diagnosis based on the test results, your primary diagnosis is going to be the confirmed diagnosis. Then there can be additional notes, and signs and symptoms can be used as additional diagnoses. For example, if you are having a diabetes test because you believe your patient's diabetic, you confirm diabetes. You would use diabetes as your confirmed diagnosis, and then you would use other additional signs and symptoms if needed. Now, let's say you're doing a diagnostic test and it's normal, and the referring provider noted signs or symptoms. Now, you're going to base your primary diagnosis on the signs and symptoms that prompted test. So, in other words, if you have a pap smear and it's diagnostic, but you're screening on symptoms, you want to use your primary diagnosis that prompted the test. Okay, and another situation is the test results are normal and the referring provider provided a rule out or uncertain diagnosis. You are going to use the primary diagnosis as the signs and symptoms that prompted the test. Okay, now we're going into the reopenings part of it. I did used to work in telephone reopenings, so this is a subject a little near and dear to my heart. So if you want to correct minor or clerical errors, that's where reopenings comes in. And there's 2 ways to do a clerical reopening. You can request it in writing with the reopenings adjustment request form, or you can call us in. And now if you call by phone, you're going to call 866-276-9558. You're going to state that you are requesting a telephone reopening, and the representative can advise you on claim corrections. So if you have questions about claims, they're not going to be the ones who are able to help you. Now, when you call, you're going to have to verify your information, your name, your MPI, your PTAN, the last 5 digits of your tax ID. Be prepared to give your patient's information and date of service. That way they can easily reference all your claims and meet all Privacy Act. Okay, you want to make sure that if you're doing it in writing, you go ahead and use the reopenings adjustment request form. The reason to use this particular form is that way we have all the information that we need to process it. There's nothing missing. You want to make sure that all the information on the corrected claim is accurate, not just the section you're correcting. Now, if you're looking at the presentation, under reason for request, there are several different options. One is for MSP, one is for canceling the claim, one is for the beneficiary name update, and then there's an other field, which is what most people use because they're going to have to give specific information. If you're changing a CPT code, changing a diagnosis, that kind of information, that's going to go in your other field. When you fill that out, the more specific you are, the better. The exact correction that you need, put that on there. Also, another real helpful thing is to be able to identify the internal control number, which is your claim number on your remittance code. That means we're going to look at the exact claim that you need corrected. That form is on the CGS website under Forms. Okay. Now, I know that telephone reopenings and written reopenings do have different rules. So what you want to make sure you're doing is if you're calling in for telephone reopenings, you can make sure that you're going to be able to get help. This chart will tell you, if depending on what correction is needing, if telephone reopenings or written reopenings can make changes. So if you're doing a whole lot of reopenings, you may want to print this out and put it on your computer so you know when you can call them when you have to do a written reopening form. Okay, now we're going to go into the appeals department, and they do the redetermination request form. Your tips for that is to include your requester's name, complete all applicable fields, send your supporting documentation, and you want to check the signature on medical records. That's very important. If those records aren't signed, they can't be considered. You want to make sure that this form is signed. Now, and this is on the CGS website. The reason to use this form again is because we have all the information that we are going to need to process the redetermination on this form, not including any other medical documentation. So you want to make sure that you're using the redetermination request form in order to appeal claims.
So if we turn it off, turn it back on, we can make
Doesn't work.
okay. It's working for now.
Marshall County, your mic is on.
Thank you.
Oh, okay. I was being told by technical people that that was happening. There are websites, tools, and self-service technology options available to assist you. So now we're going to start going into our resources. Okay? Most of you probably already know that CGS consolidated all incoming provider telephone lines into a single number. So if you're calling CGS, you're going to call 866-276-9558, and you're going to get a submenu. You're going to speak for, if you push option 1, you're going to speak with a Part B customer service representative. If you hit 2, you're going to speak with Electronic Data Interchange EDI Help Desk. 3, you're going to speak with a provider enrollment representative if you have questions on your revalidation or just general application information. 4 is going to be to request a telephone reopening. And 5, you're going to be able to speak with a representative regarding overpayment and recovery options. Okay? Also, when you contact customer service, there are 3 levels of customer service within our office. Now, if you find you need additional assistance or research, you can ask to be escalated to the next tier of customer service. Tier 1 is going to be the representative that answers the phone. They can answer your general claim questions, get your information as well as you can be needed. If you have advanced level questions, you can always ask for a Tier 2 representative. What's going to happen is that Tier 2 representative is having trouble, they'll refer you to a Tier 3. Now, what you're going to contact our customer service line for is your unresolved claim issues. If you have questions about denials, if things don't look like they paid correctly, explanations of offsets. So if you have questions about the offset, exactly, you know, who the offset's for, what's going on, why did we take the money back, why is the claim being provided for. We're going to also go into clarifications of Medicare coverage guidelines. I have a question about an LCD. Can you help me understand it? There's other information that's not available through our IVR. Any of that information can be gotten through customer service. You also want to make sure you're using our website effectively. If you're using our website, there's a lot of information out there that is available to you that can help with some of those issues. Again, that number is 1-866-276-9558, and that's from 8 a.m. to 5 p.m. Eastern Time. Okay, we've got a forms enhancement out there that you may have already discovered. You can complete your CGS forms electronically, print and mail them to the appropriate department, or you can also save electronic copies of your completed forms, which is very helpful because what you can do is you can actually save the form and then make changes to the form and not have to retype your information out. I know a lot of offices are also using electronic copies to store information that they sent in with a date so they know exactly when their redeterminations or reopenings requests went out. It just saves time and typing. You want to make sure that you're using the most current versions of the CGS form. Now, anytime we update forms, we notify you via our listserv, so just keep watching out for that. Okay, now we're talking about electronic remittance advices and MREP. Now, 26.5% of our Part B providers are still using paper remits. I'm really not sure why, because you can get your electronic remittance advice. What that does is you will receive your remittance the day the claim finalizes. So you get your information early. It also can help reduce costs for your storage and maintenance and review and filing. You can actually have a drive or have a folder in your services in your computer and actually download those remits. Now, we do have Medicare Remit Easy Print software available, and what you can do is it'll let you view your remit, and if you need to, you can print that ERA in that format. Our EDI team supports it. It is absolutely free, and if you print the ERA in that format, it looks exactly like a paper remit. You can download the software directly from the CGS website. Again, our EDI help desk is under our general information, and they'll be more than happy to help you with signing up for electronic remittance advices. Okay, we also wanted to talk about the CGS homepage. We do have a lot of great information out there. It's a great way to sign up for our listserv, also to check on most recent topics of news, anything going on. It's also where you get your forms and find out about educational opportunities. Okay, we just talked about the listserv. What the CGS Listserv does is about once a day, they send out an email with all the latest news. Now, if there's something extremely urgent going on, we may send out more than one a day. You can choose exactly what Medicare contracts you want. If you work for multiple entities, if you cover Part A, or you want information about DME, you can also get those in addition to the Part B coverage. So it's a great way to get your quick information. If you're not on the listserv, you can go out to this website, put your information in, and start getting those emails. See, Medicare contracts, that's where you indicate your information. Okay, here's where we promote ourselves. The CGS Provider Outreach and Education pages are out on our website. What we have is a calendar of events. Our workshops and seminars, we do come around to different areas of the state. I know that I have some workshops scheduled in August that are in person. We also do Ask the Contractor teleconferences. I know there's one next month, so you want to check that out. Webinars. I know that from Sharon's information, you guys really like the new provider web series. Good news. That's coming back starting in August. We're going to do probably 4 to 5 new topics through the rest of the year. So that's something to look forward to. You can request a speaker. You want somebody to come out to your office, or you work with an organization that might want some Medicare education. You can actually write in and say, hey, I would like to see somebody come out, and we can make arrangements for that. We also have an online education center. And what that online education center is going to do is it has classes relevant to the Medicare community. That is going through a little bit of growing pains, and we are updating that information. So it's good to get out there and just check it every so often. There will be new classes being added in the next 3 months. Now, if you need an excuse to go on Facebook at work, we have the CGS ABMAC J15 Provider Outreach and Education page. You can become a fan, and you'll get the latest information through Facebook. A lot of times that's where we make webinar and workshop announcements. Anything that's very relevant and quick, we put that information out there so you can see it on your Facebook feed. So you can go out there and check it out. Okay, now we're going to talk about MyCGS. And what this is the web portal that will perform online functions securely over the internet. What is wonderful about this is it's going to give special functions. It's going to be able to do your claim status inquiries. It's going to give you patient eligibility. Now, when I say patient eligibility, it's not just Part B. It's not just Part A. It's any MSP information. It's any managed care or Medicare HMO information. Any of if the patient's in hospice, with the hospice information. It's going to provide all that. It's also going to provide any of their preventative services. If the patient's had a preventative service, it's going to tell you at the bottom, and it's going to tell you the next eligible date, so there won't be a question about it. It will also provide financial inquiries, including the amount approved to pay and the last 3 checks paid, and copies of the remittance advices. Now, obviously, this is on the Kentucky homepage. If you haven't been out there, we've got some new things going on. There's been an updated, I'm sorry, I'm searching for the word. We have a new user manual out there that's much shorter and concise. There's also video education out there that will help you walk through the process. It will also give you all the information you need in order to get signed up and set up for your office. Now, participation in MyCGS. If you have an EDI enrollment agreement on file, you can be eligible. Now, if you're already electronically submitting, you already have that agreement and it's no problem. Now, if you're not an electronic submitter, you don't have to be in order to use MyCGS. You just have to have the agreement on file. Now, the EDI enrollment agreement is located in the EDI enrollment packet. What you'll do is download the packet, fill out the information, and send that into our EDI department. Now, when this all started, the application for process is about 20 days from the time they get it. It usually runs a little shorter, but they can get that information in there for you in order for you to get qualified for MyCGS. Okay? Now we're going to show you some screenshots of MyCGS just so you can see what's going on. The claims box is going to be able to check the status of your Medicare claims. The remit is going to be able to view and print copies of remittance advices. The eligibility will also give deductibles and therapy caps, and home health and hospice dates, and any inpatient or skilled nursing facility information. Your financial tools will give the number of claims approved, the amount approved, and the last 3 Medicare payments. Okay, now let's go into the resources. Again, I mentioned the CGS video library. It's going to give you, there's one called the Benefits of MyCGS, and that's going to include the MyCGS 3-part video tutorial, which we recorded in Nashville. You can go out there. It's less than 10 minutes for all 3 parts. You can listen to that. There's the web portal registration checklist. So if you're not enrolled in MyCGS and you want to, you can print that out. You'll have all the information you need in order to get registered. It'll walk you through the process. There's the MyCGS frequently asked questions, and that's the questions that we get during webinars and seminars about MyCGS. We add that information in. There's the user manual that's just been updated. And any questions, refer to the EDI help desk. They'll be more than happy to help you with those. Okay, I'm going to go back to MyCGS a little bit. If you're currently using MyCGS, we do have some really good changes coming up. I can't tell you when, and I can't tell you exactly what, but it's good stuff, and it will be shortly. So you want to make sure you're watching for that if you're currently using, because you're going to be very excited about some of those changes. Okay, we've kind of completed the class, kind of breezed through that. I'm hoping that there's going to be some questions. So does anybody have questions?
I actually have a question.
Okay, great.
The PQRS, it's a simple question.
Okay.
I know that it's too late for them to get incentives, but it's not too late for them to be penalized, correct?
That's correct.
Okay.
If you are If you are trying to beat the penalization for 2014, that's what you're asking, correct?
My question is, they're doing claims reporting,
Uh-huh.
and that's just happening through the fact that they're filing claims.
Right.
Do the health departments need to call CGS or whomever and let them know that that's the claim, the reporting option they're using? Is there anything they can do to avoid that penalty?
Okay. What they can do to avoid the penalty, there's a couple of things. They can contact QualityNet, which is in the presentation, and they can give that information through QualityNet, and they can set you up for a hardship or an exemption request. That's going to be through QualityNet, and I can't guarantee they're going to give it.
Okay.
Also, it is not too late for 2014. You only have to file 10 prior to 2014, which is December 31st, in order to qualify and get that and not have to pay the penalty.
10 claims
Yes.
with the parameters that you guys have set.
Yes. So, if you go to QualityNet and QualityNet is not amenable, if you can just start, get those 10 claims in, get them processed, that's not a problem at all.
And they're calculating that at Medicare.
Yes, that's through CMS. CMS is the one who is actually making the calculations, but QualityNet can give you a feedback report as
Okay.
part of that, so you'll know.
So a provider, a health department could call QualityNet and say, where do I stand? Have I met my requirements?
Absolutely. And what you'll need to do is wait for the claims to process, obviously, and once those claims process, then they can confirm. They can confirm that.
Okay. That's helpful, because that program has been confusing.
It is very confusing. I will not disagree with you.
Thank you.
Can you repeat the question?
Linda, it's Nellie. I just asked her about the PQRS and how health departments can avoid the penalty of PQRS, and she answered that. Did you catch the answer?
She was asking about the PQRS and avoiding the penalty for public health departments. And what I was telling her is that if you can contact QualityNet and ask for a hardship, but most of the time they're not giving hardships on PQRS. But what you can do is file the minimum requirements for PQRS standards, send that information in, and by the end of this year, December 31st, and then you will avoid the penalty. Does that make sense?
Yes.
Okay, great.
Is there a special code we put on the claims for PQRS?
Yes, there is, but that is very specific as to what PQRS service you're providing. There's a list of about 300 different services that you can provide for PQRS. On our website that has the specific, on the CGS website, they have a specific booklet of all the services that you can provide for PQRS. And that's where you're going to get your code from.
Flu shots are on there.
And flu shots are on there.
Pneumonia vaccine is on there.
Is pneumonia on there?
Yeah.
I knew flu shots were. I didn't know about pneumonia.
I feel like they'll be covered with flu shots.
Yes, absolutely. Flu shots are huge. And they need to be huge. Okay? Do we have any other questions? Have I bored you to tears yet?
It's overwhelming.
It's a lot. I know it's a lot of information.
But MyCGS enrollment, you said if they already have an EDI enrollment form active, like our billing vendor is on our EDI enrollment form, so they get our some of our payment information for those who have signed up for that.
Mhm.
So they get those 835 files back. Can we still get both? Can they have MyCGS, see all that, plus our billing vendor continue to get those files?
The question that was asked was about, if you have a billing vendor and the ones who have the EDI agreement on file, can we still use MyCGS? Yes, you can. What you'll need to do is contact our EDI department. They'll be the ones who can help you set up the account for you for MyCGS. Does that make sense? You just contact EDI, indicate, our billing software people are the ones doing the EDI agreement, but I need to go ahead and get MyCGS set up for me. And you absolutely can do that.
That's an awesome service.
Yeah.
Yeah, I didn't know that.
Yeah, it's really fantastic. And I know that one of the previous contractors for Ohio was the one who introduced the concept of the web portal. But it's very, very helpful if you're just getting your information on claims to be able to go out there and get it. And eligibility.
Can you rebill a claim there?
No, you can't. Not at this point. It could be coming.
Aha.
Or, making corrections on claims could be coming. We are waiting with bated breath to see exactly how the next year is really going to change MyCGS.
Okay, ladies, sign up for that.
This is Angie with Wedco. I have a question.
Sure.
I'm a little confused. The only thing I bill to Medicare is flu shots. I tried to go on and apply for the exemption, and they said because we don't bill any scripts that we didn't need the exemption.
That's
so
correct.
will we see a 2% decrease in our flu shot payments, or will we be fine?
You will not. Since you are not billing with that denominator, saying usually the denominators are, your office visits, that sort of information. Since you're not billing the 10% minimum, you will not see a reduction because you automatically qualify. You guys are doing flu shots. Another great example is radiology. Radiology, they never see the patient. They just do the radiology services. They're not billing any kind of office information, so they're automatically exempt. So you guys are automatically exempt for if you're just billing flu shots for electronic prescriptions.
Okay, thank you.
You're welcome.
Now, if you're a health department that has a flu provider number and a regular group number, this could affect you because you have that regular group number, where you have maybe a registered dietitian, and you may not be billing any other services by a nurse practitioner. So that's where you would needed to have gotten the hardship exemption.
Hi, we're back from break, and we're getting ready to start preventative services. Again, my name is Melissa Kress, if you didn't get it the first time. We're just going to go over some of the preventative services websites. I realize that some of this information will be useful to you, some of it might not be, but make sure that you're taking notes because there's a lot of great information on the websites. Doesn't this look familiar? This is our disclaimer indicating that this information is valid on the day I've presented it. Okay, what our objectives are going to be today is to identify covered preventative services. We're going to discuss coverage limitations for those services, provide coding and diagnosis information for specific preventative services, and introduce resources for preventative care, including identification of beneficiary eligibility through the MyCGS program. Okay, what we're going to do is we're going to do a preventative services web safari, and what that's going to do is provide you the resources for Medicare preventative services. So here we go. Okay, the first thing we're going to look at is the quick reference information for providing the initial preventative physical examination. There's always questions about this in most of our classes, so we're going to open that file and take a look at what we've got available for you.
This is Sharon. I want y'all to pay attention to this, even if you're not doing it. You could have some of your physicians in your area that want to contract with you all to maybe provide the subsequent AWB, and this would be helpful to you if you all decide to go in this direction. Sorry.
I was trying to pull the website up. it's down there. Okay, let me do that. I can do that, that's not a problem. There it is. Yes. I'll expand it out. Perfect. Thank you so much. Okay, here's what we've got. We've got the quick reference information for the physical exam. What the important things is the components of that IPPE and indicating the beneficiary history. You want to make sure you review that medical and social history. You want to make sure that you're reviewing the beneficiary's potential risk factors for depression and other mood disorders, and review the patient's functional ability and level of safety. You want to begin the examination with your examination. We do want you to offer end-of-life planning for your patients, education, counseling, and referral based on the components that you've discovered, and counseling and referral for preventative services. This particular website also offers the Part B preventative services information on things the patient may not know that they are covered for. Bone mass measurements and cancer screenings and diabetes screening tests. We're going to go over those in some more detail. This is going to give you, your next page on this is going to give you the actual IPP HCPCS codes, which are going to include the codes for the actual IPPE and the electrocardiogram, which is part of that covered service. It's going to give you all the information on who can provide the IPPE, the yearly physical information, laboratory test, evaluation and management services on the same day as the IPPE. This just gives a lot of really great information if you have doctors or nurse practitioners or other servers who may be interested in providing IPPE. Amazing statistics on this is this IPPE service is not being utilized enough. Most beneficiaries don't know that they have an option. It may be something that you want to think about suggesting to your patients. Okay. Okay. Now, there's different levels of the IPPE, obviously. You have the initial, which is for your patient's first 12 months in Medicare. If they've already met that 12-month requirement, they can get an annual wellness visit. They can obviously get this visit once a year. And there's a website talking about that. Okay. All right. Again, there's a list of elements that you have to give for the first AWV. That's your health risk assessment, the medical family history, the potential risk factors for depression and mood disorders, review the beneficiary's functional ability and level of safety. Again, you're going to give your assessment, the establishment of the list of current providers or suppliers. A lot of times beneficiaries have different services of care and different providers providing services. So that AWV needs to cover that information. Give me just one moment. Sorry. Now, you want to make sure that you have any detection of cognitive impairment that the beneficiary may have. And then you're going to provide any counseling that the patient might need. A written screening schedule for the beneficiary, such as a checklist for the next 6 to 10 years, things that they may need to think about getting, such as a colonoscopy and pap smear information. What? No, I'm okay. Thank you. An establishment of risk factors and condition for which the primary, secondary, or tertiary interventions are needed or recommended. And giving personalized health providers advice to beneficiaries and referral to health education or preventative counseling services. Again, it's going to go over more of the Part B preventative services. It's also going to give you your coding information for the annual wellness visit, and that is going to include your personalized prevention plan of service, and then your annual wellness visit, which is subsequent. It's also, again, going to give you the frequently asked questions, indicating diagnosis information, evaluation and management services, and a list of resources that you can refer to. Again, it's always good to give the beneficiaries this information, even if they're coming in for their just general flu shots. You know, say, hey, have you went and had your annual wellness visit or your IPPE if they're new patients? It's a good resource for them. It also ups that advantage for them. It ups your state average as well. Okay, now we're going to go into diabetes and bone mass measurements. And we're talking about the diabetes screening test and self-management training. And this is a diabetes-related services fact sheet. Okay, and it's a very short sheet indicating what we cover for diabetes services. It will tell you exactly what the criteria for diabetes is, or pre-diabetes. It gives you information on the screening test that we cover, the fasting blood glucose, a post-glucose challenge test, an oral glucose tolerance test, and a 2-hour post-glucose challenge test alone. It'll give you the coverage information, which indicates all the information here is coverage, has coverage for these tests. Now, if your patient is diagnosed with pre-diabetes, we cover 2 diabetes screenings within a 12-month period. For pre-testing, we obviously cover coverage for 1 diabetes screening test within a 12-month period. And the 12-month period is at least 11 full months have passed following the month in which the last Medicare-covered diabetes screening test was performed. For example, if you saw the patient in February of 2013, let's say on the 13th of the month, they would be eligible again after 11 full months have passed, which means on February 1st, they would be eligible again. Now, something that you may see a lot is diabetes self-management training. Now, we cover those for patients that have been recently diagnosed or be at risk, were determined to be at risk, or previously diagnosed with diabetes. We cover them from certain providers. And the DSMT program includes the following services. One moment, please. I apologize for that. The instruction in self-monitoring of blood glucose, education about diet and exercise, an insulin treatment plan developed specifically for insulin-dependent beneficiaries, and motivation for beneficiaries to use their skills for self-management. Now, we will cover that if the treating physician or qualified non-physician practitioner managing the diabetic condition certifies that those DSMT services are needed. It is a Part B benefit. Again, medical nutrition therapy is covered for renal disease. They also cover those services. The beneficiary has diabetes or renal disease. They have a referral from the treating physician. The number of hours covered in an episode of care may not be exceeded unless a second referral is needed. The services are provided within the same time period and under the maximum number of hours allowed under each benefit. Then we go into the office supplies, which you probably don't see a whole lot of, but it does give all the information on that. So this is great for you or your patients, so they know exactly what kind of services they're getting that Part B will pay for. Okay. Now, bone mass measurements. This is, you don't want to review bone mass? That's okay. We can.
They can refer them.
Okay. Well, if there's something on here that you don't think they need, just let me know.
Okay.
And I'll skip it. Screening pap test. This is just a really quick little booklet that goes over screening pap. Okay, good deal. This is a very in-depth booklet. Some of the booklets are about 16 pages. Obviously, we're not going to go over all the details. I'm going to wait for this to completely load this time.
Be excellent for them to give to their providers.
Absolutely. These are excellent for anyone. You know, for you guys to read over, give to your providers, so they're very much in tune with what Medicare recommends and what Medicare will cover. Okay, just to start with, Medicare Part B covers a screening path for asymptomatic female beneficiaries every 24 months. Again, that's the full 23 months after the last service. Now, Part B will cover an annual screening path for female beneficiaries that meet one of the following criteria. There's evidence based on medical history of high-risk categories for developing cervical or vaginal cancer, and her physician recommends that she have the test more frequently. And a woman of childbearing age who has had a PAP within the preceding 3 years that indicated cervical or vaginal cancer or another abnormality. Okay. The best part that I love about these booklets is that they give you the coding information that you need in order to process. There's the HCPCS codes for the screening paths listed, the interpretation of screening paths, and then the laboratory code for the specimen. I got a little click happy, I apologize, which is your Q0091. There's also the diagnosis requirements, which I also love, because then that way you know exactly what you need to build to get them processed, you know, for your routine exams or your high-risk diagnosis. You know, it also gives you the billing requirements when you're submitting your professional claims, which would be your Part B claims. It goes into a whole lot of detail about institutional claims. Okay. You know, it will also give you the reasons for claim denial and any resources you might need. So this is a very thorough booklet on pap smears. And so if you're performing a lot of them in your office, this is a great resource. Okay. Screening pelvic examinations booklet. Is going to be a lot of the same. Again, it is a very large booklet. I believe it is also 16 or so pages. It's going to have your overview, what the screening elements that have to be part of the service. They have to include 7 of the 11 elements, which are listed here. They also have high risk factors, the frequency limitations of 24 months or 12 months, depending on low or high risk, the coinsurance, copayment, and deductible, since the patient will not pay anything, no coinsurance or copayment, and no Part B deductible for the pelvic exam if conditions of coverage are met. Again, best part, it has the coding and diagnosis information so that you're very sure of exactly what you need to be billing in order for the services to be processed. The G0101 is your HCPCS code. It does have your low-risk screening pelvic and your high-risk screening information. So this is what you're going to need in order to process claims. There's also more information about the billing and coding requirements, types of billing, payment information, your reasons for claim denial. Again, the reasons for claim denial, you can get those through MyCGS, or you can get them through your rep and reading that remittance advice. So that's a whole lot of information. There's a good resource page. There's several resources on here that I'm not even going over that you can also pick out that you may find informational. Okay. All right. Screening and diagnostic mammographies. Again, another large booklet. Medicare doesn't believe in doing anything halfway. They like to give you as much information as possible if they can make it clear on things such as mammographies, your general services. It does have coverage information indicating it doesn't require prescription or referral. It tells you what a screening, the definition of a screening mammography and a diagnostic mammography. That way that you can code it appropriately. How frequently they cover it. If between ages 35 to 39, they pay for one screening. It's called a baseline mammography. And after age 40, they cover it once a year. Now for your screening mammography, there is no co-insurance or co-payment or deductible application for that screening mammography. Now for diagnostic mammography, the beneficiary would pay the co-insurance or co-payment and any Medicare deductible. Okay, again, the diagnosis and coding information, it will have your applicable CPT codes with descriptions of the codes, and also the diagnosis requirements of the V76.11 and the V76.12. But then you go into the billing requirements and further resources. This is a great one if you want to give to your referrals or radiology services, or just to have on hand to give to your patients so that they know that they are eligible for the service. Okay. We can go into ultrasound, skip the ultrasound. Cardiovascular?
They can look it up if they need to.
Okay. Do you want cardiovascular? Are you good?
I think we can skip that.
Okay. HIV screening? Okay. Okay, I can do that. Okay, we're going to go into the HIV screening services. Okay, this is very short. It's only a 2-page fold. So we do cover HIV screening for services. Now, this doesn't give the actual testing information, but it will give information on what is considered a risk factor. It indicates, of course, there is no cure, but it gives information on how to result in the screenings, and those risk factors. It also gives coverage information. And what we do is they cover once annually for beneficiaries at increased risk, and a maximum of 3 times per term pregnancy for pregnant Medicare beneficiaries, beginning with the date of the first test ordered by the clinician, when the diagnosis of pregnancy is known, during the 3rd trimester, and at labor. So, again, your medical record documentation must show that the coverage requirements were met. It's just a very basic pamphlet letting you know that it is a covered service. Then we go into sexually transmitted infections and high-intensity behavioral counseling to prevent STIs. And your internet works far better than mine. This is an MLN Matters article, and it's MM7610. What this is indicating is that STIs will be covered for chlamydia, gonorrhea, syphilis, and hepatitis B with the approved clear laboratory test when ordered by primary care. Okay. Again, your code for the diagnosis is G0445, and the appropriate screening diagnosis, which is listed right here, V74.5 and V7389. There's also V69.8, V22.0, and V23.9. And this is defined as a 12-month period for coverage. There's also specific codes for the screening of chlamydia, gonorrhea, syphilis, and hepatitis B with your diagnosis. So you want to make sure that you're using the appropriate information. Now, screening, again, is for pregnant women, women at increased risk. Screening for syphilis is men and women. Hepatitis B, again, pregnant women at the first prenatal visit. Okay, we have high-intensity behavioral counseling. CMS will cover 2 individual 20 to 30-minute face-to-face counseling services for Medicare beneficiaries to prevent STIs for sexually active adolescents and adults at a increased risk for STI. That includes education, skills training, and guidance on how to change sexual behavior. Any of the following are included as high risk: multiple sex partners, using barrier protection inconsistently, having sex under the influence of alcohol or drugs, having sex in exchange for money or drugs. The age is also a factor, having an STI, IV drug use, and men having sex with men and engaged in high-risk sexual behavior with no regard to age. This is something that has just recently come for coverage, so you want to make sure that your doctors know that that is a covered service. Okay. Get colorectal prostate cancer screening and glaucoma.
Oh, they can check that if they need to.
Okay.
Just get both of those.
Tobacco, alcohol.
Yeah, they do all of that.
Okay. We're going to go over counseling to prevent tobacco use for asymptomatic beneficiaries and the tobacco use cessation services fact sheet. Hello.
It thinks it's in the text box.
Whoa. Come on. There. Where did you go? No. Ah, okay. Okay, again, the tobacco use counseling services, just a very short document brochure to cover what tobacco use cessation counseling services are. The coverage information for symptomatic beneficiaries. Medicare will cover 2 cessation attempts per year. Each attempt may include a maximum of 4 intermediate or intensive counseling sessions. So the annual tobacco intake covers up to 8 smoking sessions in a 12-month period. The beneficiary can receive another 8 counseling sessions during the second or subsequent year after the 11 months have passed since the first Medicare-covered cessation counseling session was performed. The coverage information, Medicare provides coverage of counseling to prevent tobacco use for outpatient and hospitalized beneficiary for patients who use tobacco. So coverage criteria, the beneficiaries must be confident and alert at the time the counseling services are provided, and it has to be furnished by a qualified physician or other Medicare recognized practitioner. A counseling session refers to face-to-face contact at an intermediate level, greater than 3 minutes and less than 10 minutes, or intensive, greater than 10 minutes. This can be performed incident to the service of a qualified practitioner. There's lots of resources for this and a lot of beneficiary-related information which you can give to them in order for them to get further education on it. Okay, now this is screening and behavioral counseling interventions in primary care to reduce alcohol misuse. Okay. Again, Medicare loves to give you lots of information. The risky or hazardous drinking information is for women more than 7 drinks per week or more than 3 drinks per occasion, or for men more than 14 drinks per week and more than 4 drinks per occasion. Your coverage information is indicating that patients every 12 months can have information for when they misuse alcohol, but patterns of alcohol consumption do not meet criteria for alcohol dependence. So you're looking for 3 of the following: tolerance, withdrawal symptoms, impaired control, preoccupations with acquisition or use, persistent desire or unsuccessful efforts to quit, sustained social, occupational, or recreational disability, and continued uses despite adverse consequences. They also have to be competent and alert at the time the counseling is provided, and whose counseling is furnished by a qualified primary care physician or other primary practitioner in a primary care setting. Behavioral counseling intervention also goes by the 5 A's: assess, advise, agree, assist, and arrange. But the coding and diagnosis information is also in this booklet with the G0442 and the G0443 with your definitions, and it gives you information on your diagnosis requirements. So check that out and make sure your beneficiary knows that's a covered benefit if they're wanting to change their alcohol use. Screening for depression? No?
I mean, unless they're going to do those AWV visits, and they can look that up.
Okay. You could use the screening for depression if you're going to do your AWVs or your IPPEs. Also, intensive behavioral therapy for obesity. Okay. We're going to go over that. So let me pull that information up for you. Okay. Again, this is another Medicare booklet with all your information about the IBT. Okay. So it does include the coverage information, which indicates that they cover for a body mass index of 30 or greater. They do a dietary and nutritional assessment, of behavioral counseling and behavioral therapy to promote sustained weight loss through high-intensity interventions on diet and exercise. The patient has to be competent and alert, and the counseling has to be furnished in a primary care physician or primary care practitioner setting. Again, it does go over the coding and diagnosis information for the G0447 and the diagnosis codes that are covered for that service. It also has billing requirements and resources that may be practical for your office. So you can take a look at all that. Payment information and resources.
Does it say who, like what type of practitioner can provide that?
The question is, what kind of practitioner can provide the services? Who are primary care physicians and practitioners? A physician who is a primary specialty of family practice, general practice, geriatric medicine, internal medicine, OBGYN, and podiatric medicine, or a non-physician practitioner, which is clinical nurse specialist, nurse practitioner, or a physician assistant. Okay. We're kind of getting to the end of the presentation here, but I'm going to give you really, really good resources. The first one is going to be the Guide to the Medicare Preventative Services. We're not going to go over all this. Yes, if you have questions, this has got it. It's 298 pages. If there are things that you want to know about preventative services, broken down completely, it's going to give you that. However, just a little cheat for you. These different chapters are in the booklets that I've given you as well. But it has everything. It also includes your influenza, pneumococcal, and Hep B vaccinations. There's a big series on that. It gives you information about mass immunizers and roster billers, diabetes, glaucoma, screening paths. This all looks familiar. So it does have everything you need in there. Again, it is a very, very long booklet. However, in my humble yet deadly accurate opinion, this is my favorite thing that CMS has ever done. This is the quick reference information for all preventative services. What this does, I'll see if I can zoom in a little bit. Yeah, there we go. This is going to give you the name of the service, the HCPCS codes, a specific diagnosis, who's covered, how often it's covered, and if the beneficiary has a co-insurance or deductible. It does it for all the services we just went over. Now, these are fantastic. This is on our this is on the website. You can pull it up. If you want a good copy, you can do one of two things. You can go through the MLN Matters website. You can actually order a copy of this, and they will send you a beautiful copy that is laminated and has a ring in it, so it's all together, because it is several pages. But it has everything. Or, either I can send a lot of them to Sharon, and you can distribute them, or you can ask me directly for them, and I'll send you out a copy direct to your office.
I think most of them can print them.
Or you can print them. I mean, that's completely your thing. But these are just really nice copies. So, that's something for you to think about, because this is, again, one of my favorite things that CMS has ever done, because it breaks it down beautifully into exactly what you need to do.
This should be in the back, in the clinic setting, where every nurse practitioner and all the nurses who do the workups can see this.
Yeah, I mean, it's a great resource for anybody billing services, anybody looking for services. This is going to give them everything they need. Okay? Let's close that. Now we're to the question point of this. So does anybody have questions, comments, thoughts? And it doesn't have to be, and don't think you have to have questions related to preventative services. You can ask me questions about anything.
Yeah, this is Debbie in Barren River.
Okay.
I have a question about the Hep B. We've been trying to bill a few Hep B's vaccinations. And we had issues with getting those paid. And we were given the diagnosis, which we use as the V053. And they've kicked them out because it's not medically necessary.
Okay.
They paid the administrative, but they kicked out the vaccination charge for not medically necessary.
Okay.
So how can I go, what do I need to do to get those?
Well, the first thing I'm going to do is I'm actually going to pull up the big guide and see if it has it in there. I know that Hep B has very, very specific criteria for payment, and proof of it can sometimes be where the problem is. But let me take a look.
did you have a qualified practitioner doing the service?
We billed it under, yes, Dr. Thompson. We
Okay, just checking.
Okay, it says your diagnosis and information should be payable. You're billing with the 90740? What what HCPCS code are you billing with?
90746.
No, it's for adult. Okay. Okay. You know, if you don't mind, would you mind giving me a call and I can actually look at some of your claims and see what's going on with them? Would that be okay?
It'll be fine.
Okay,
Can
let me
give
give
you
you my
a phone
number. Yeah, absolutely. It's sad I have to pull it out. They just changed it. It's 336-821-4559. Or let me make it easier for you. If it's easier for you, you can email. My email address is Melissa, MELISSA, .Kress, KRESS, at cgsadmin.com. It may be easier to catch me by email. If I am not in the office, that's my office number. It's far easier to get me by email.
Okay.
And I'm happy to look some of that information up for you, see kind of what's going on.
Okay.
Great.
Thank you.
You're welcome. Does anybody else have questions? You don't have to be shy. And if you have questions, you know, you're more than welcome to email me. That's not a problem at all. That's what I'm here for. You know, of course, you know, my questions are considered to be advanced if they're about, you know, usually claim issues that are not large scale. They need to go to customer service. But if you're having large scale claim issues, that's when you email me, or you have something specific going on. Anybody else have questions? Doesn't have to be about preventative services again. I'm here for you guys.
Y'all have any flu shot issues, flu shot questions? All right, well, we're going to wrap it up.
Well, I wanted to
Anybody
thank.
has any other questions?
I want to thank everybody for attending today. Again, my name's Melissa Kress. If you need me, you have my email address. Please feel free to get in touch with me. Thanks for your time.
Thank you.